So the outline of my presentation is going to include why actually men do develop urinary incontinence after a prostatectomy. We're going to talk about the pelvic floor muscles. Where are they? What are they? Why and how? I'm going to talk about one particular case study, and we are going to talk about a little bit of a discussion afterwards. Just in reference to what Patrick spoke about earlier, and someone did ask about discontinuing therapy, or do people need to have ongoing therapy for erectile dysfunction? I've got some of my patients, some are actually here today, that have done exceptionally well both continence and erectile function management, and like Patrick was saying, the consistency definitely was the key. This particular fellow had compounding problems by severe urinary leakage. Both him and his wife are very diligent and supportive in terms of their recovery. It's been over 18 months now, and they started off by using the tablets and the pump very regularly, and they were able to have intercourse. They're now able to do that without the use of the pump or the penile ring at all. So it goes to show that early intervention works best in a supportive environment, and lots of consistency definitely does pay off. Okay, now why does a prostatectomy cause urinary incontinence? When the prostate gland essentially is removed, regardless if it's radical or robotic assisted, the whole entire prostate gland is removed, and so too is part or all of the bladder neck. And inside that bladder neck we have the main or internal sphincter. And that particular muscle is responsible for holding urine inside the bladder. So as a result of this, the secondary or external sphincter needs to be trained to take over. So that's where we come into play, in terms of we like to train these muscles as early as possible in order to actually take on a much bigger role. Now PPI, or post-prostatectomy incontinence, is basically incontinence after prostate surgery, and it affects between 3 and 98% of all patients. Now if I see a patient preoperatively and they are convinced that they are going to be one of those 1 or 2% that don't get incontinent, I don't like to shatter their dreams, but I like to make sure they are realistic for what is more likely going to happen. 50% of men are dry or pad-free within 6 to 8 weeks. So that's the statistics that I quote to all my patients preoperatively, in that expect, if you're in the top 50%, you may need to wear pads for up to 6 to 8 weeks. If I see a patient that's coming in, they're going overseas in a month and they are quite concerned about needing pads, I would prepare them to actually take pads with them, because we don't know how they're going to be after their surgery. 95% make a full recovery. By a full recovery, we do talk about a pad-free environment by 12 months. But further recovery can occur up to 2 years. I'm seeing some of my patients that are making progressive improvements by more than 18 months to 2 years. Now in terms of incontinence, the severity varies a lot. And when we see someone preoperatively, we cannot predict who is going to only leak a little bit and who's going to leak like nobody's business. In terms of mild incontinence, that is classified as 1 or 2 pads per 24 hours, which equates to less than 100 mils or 100 grams in that 24-hour pad weight total. I do get all my patients to weigh their pads because it's much more accurate and objective than working out the number of pads. That level of severity can increase, unfortunately, to severe or astronomical amounts of urine, which is up to 6 to 8. I've seen 13 and 15 pads per day, leaking more than 300 mils. I've seen guys leaking more than 1 litre. And for a man that is not used to having anything leak outside their body, if they're leaking 1 litre, it's a very devastating and traumatic experience to be dealing with. Okay, now the treatments for incontinence. Now what I do is basically we do pelvic floor muscle and bladder retraining. We do that before, nowadays, the actual incontinence develops. So most of the urologists do send patients to me preoperatively, which obviously has proven to be beneficial in terms of not waiting till they've had their surgery and that they're leaking 6 to 8 pads a day. Other things we use, like the pads or pull-up pants, is occasionally I will prescribe a dribble stop clamp, which is up the top, just there. Now I know some of you in the room tonight have used the dribble stop clamps before. I use them for severe incontinence early on in the recovery stage, if it's compounded by severe distress, because I see guys that are absolutely devastated and they refuse to leave their house, they become quite depressed and they develop bad bladder habits or negative bladder habits because they're leaking so atrociously. When we do prescribe these dribble stop devices, I make sure that they only use temporary, and I do incorporate the exercise program with and without the dribble stop on. Now, if for some reason those particular patients, that small percentage that do not get to where they'd like to be in terms of their recovery of incontinence, there are alternative treatment options available that Dr. Cozzi did talk about briefly. In terms of surgery, the two options are there's the sling, the Virtue sling, which is on the monitor at the moment, and the alternative to that is an artificial urinary sphincter. Now, these particular devices are only used for a small percentage of men that don't achieve continence in that 12 to 24 months, and they are used for gentlemen that are bothered by their incontinence. Now, I'm a big favour of treating bother rather than anything too objective. I have patients that leak 500 mils a day and they've had their surgery. Their level of bother is decreasing because they're getting used to it and they don't really want another operation. And I can appreciate that. That is purely their choice. But I always educate my patients to determine how much they're distressed by their incontinence, particularly if they've reached a plateau in their recovery, they may not get any better still. And we do talk about what the treatment options are with these slings and sphincters. Now, the slings are getting even better in terms of improving the level of incontinence. They were previously used for more mild incontinence, where now they are being used for more severe incontinence and up to 6 pads a day and getting some significant results in terms of maybe not getting them bone dry, but actually significantly reducing their pad weight numbers and improving their quality of life. Okay, just a revision of the anatomy here. This is quite a good side picture of the actual male anatomy. This is prior to the prostate surgery being performed. Now you can see the bladder on top, and it's very close to the prostate, which sits below there. Now with the radical prostatectomy, that whole prostate gland is removed along with the seminal vesicles and part of the bladder neck as well. Then the bladder gets drawn down. And you can see on the side view there where the pelvic floor muscles sit, how they sit directly below the prostate. So this is just another view in terms of the side, just familiarising yourself with the anatomy in terms of where things sit, or where they did once sit. Okay, now what weakens the pelvic floor muscles? Now, surgery doesn't necessarily weaken them, we just have to rely on them more because part of the mechanism that keeps you dry has been removed. But other things can contribute to weakening of muscles. The ageing process, I don't tend to harp on about that because we have no way of controlling that, we cannot change it, so that's just one thing. Obesity is a big thing in terms of my mind, and a lot of my patients here will know that if you are carrying any weight, I will bring it up, and I will probably even work out some strategies to help you in terms of reducing that weight. Not only for the benefit of your continence, but general health. When we know if you've been cured of prostate cancer, the next thing we want to stop you from dying from is heart disease. So if you have a waist measurement of above 95 centimetres, you are at risk of, you more likely will already have pelvic floor muscle weakness. So you're going to know this when you put your undies on and you know what size they are. And I'm hoping you know what size you are, then you don't have to rely on your wife to tell you what size undies you wear. Okay, other things that definitely weaken the pelvic floor muscles include pregnancy, just actually carrying the baby around for 40 weeks, and the actual childbirth process. Things like a chronic cough as well, chronic constipation, heavy lifting, or some neurological disorders like spinal cord injuries, Parkinson's disease, MS, and a few other neurological problems like that as well. Okay, on this slide we see a comparison, of strong pelvic floor muscles on the left versus weak. And just like other muscles, these muscles actually atrophy, so they shrink. So if muscles are not used, they shrink. Just like with in terms of erectile function, you do get shrinking of the penile tissue if it's not used. So the same thing applies here. And you can see with the weakened muscles that you are potentially likely or going to get involuntary leakage. Okay, this slide just compares the various types of urinary incontinence in men. The most common I see definitely is stress incontinence, and that's particularly after the prostate gland is removed. But we do see a combination as well. I do see gentlemen that don't have prostate cancer and that just have a benign enlargement. So if you look to the right, the overflow incontinence we definitely see caused by a blocked urethra. I also see a combination of both stress and urge, where the urge incontinence definitely has a bit of a trigger, whether it be like turning on a tap or putting your key in the front door or pulling down your undies to go to the toilet. That may trigger a sudden letdown and your bladder just contracts and you have no control over it, and it's very debilitating and distressing. So we have to essentially diagnose the type of incontinence to begin with, whether it be a combination or individual, and then appropriately design a program, whether it be pelvic floor retraining or down training and bladder training at the same time. Okay. Now, what are the functions of the pelvic floor muscles? Now, so far I've probably treated about 600 men with prostate cancer, and even prior to that I did talk about pelvic floor muscle exercises in a lot of my male patients. Quite a few were surprised that they actually had pelvic floor muscles. They thought their wife did, but I soon educated them a little bit further. Now, the first function, there's in no level of importance, these functions, is support and stability. Now, the pelvic floor muscles act like a sling or a hammock, and the pelvic floor muscles secure the pelvic organs in position. They also contribute to core and pelvic stability. Now, core stability is a bit of a, I suppose, catchphrase that we hear, and the pelvic floor muscles make up the bottom of your core muscles. The top is the diaphragm, the bottom is your pelvic floor, the front abdominals is your deep abdominal muscles, your transverse abdominis, and the back is your rectus spinae and your multifidus. Now, these muscles do not get strengthened by sit-ups, and they are not your six-pack muscles. I see a lot of fit young guys that look pretty ripped, they have poor core stability. They look strong, but when you assess them properly, their level of stability is exceptionally poor. Where I've seen other patients who have a degree of abdominal fat, with training, they've actually got stronger core muscles than a more fitter looking character. Okay, now sphincteric. So that's, I suppose, what I do in some regards, in terms of we talk about the sphincter and the fact that one of them has been partially or fully removed, and it functions to actually aid in the interruption of the urinary stream. And also, the pelvic floor muscles can help push out the last few drops of urine. And particularly in females, the pelvic floor muscle tightens the vaginal area, and with men and women it does tighten the anal and rectal areas as well. Now, in terms of the sexual function, this is what Joe was talking about previously in terms of the evidence that we are helping improve not only continence with pelvic floor muscle retraining, but also sexual function and erectile function. So a lot of my guys, once they achieve continence, it is important to continue their exercise therapy to facilitate further recovery from the erection point of view, not just the continence point of view. Now, with sexual function, the pelvic floor muscles helps to maintain an erection. They also contract rhythmically during orgasm and helps facilitate ejaculation. Okay. Now, why should men perform pelvic floor muscle exercises? There's obviously a list of benefits there. We want to improve your urinary incontinence. We want to improve your terminal dribble. We want to improve your erectile dysfunction or reduce the dysfunction. We want to increase awareness of sexual sensation and enhance enjoyment. We also want to reduce the incidence and severity of chronic low back pain. As I mentioned earlier, when I treat traditional back pain patients, I always talk about their pelvic floor muscles. And I treated a fellow last year who had chronic low back pain, who was very overweight and very inactive, but in saying that, he had lots of physiotherapy over the years for his surgery. For his back, he did have surgery. To my disappointment, I suppose, he was never shown how to contract his pelvic floor muscles previously to aid in his treatment of his low back pain. Now, what a surprise, after 6 weeks of pelvic floor rehabilitation, not only did his incontinence improve, but surprise, surprise, his back pain wasn't as bad, and he's had it for 20 years. So that's another benefit in terms of management of these other conditions. Okay. Now, pelvic floor muscle exercises. The first thing we have to identify is the correct muscles. Now, I will sort of disperse into my talk different mistakes that I see all the time, and quite often the mistakes are not only that the muscles are incorrect, but they're using the wrong muscles at the right time and the wrong incorrect sequence. So the technique is very important, and so too is the correct prescription. We also want to establish a habit, and we want to incorporate or progress to functional training, and as I said, we will talk about common mistakes. Okay. Okay, so this is just a view from underneath of where the pelvic floor muscles sit, and a comparison of the male versus female. They're very similar, but the muscles do, there's the rectum there, and there's the pelvic floor muscles around there, and going up there as well. Now with the correct technique, I do talk about usually 3 components, but with each individual patient, I will get them to show me how they're trying to elicit a contraction first, and then I will change what we do based on what I see. So I don't give everyone the same thing. I definitely don't go for immediately telling someone to tighten the muscles around their anus, because I've seen so many men with tight glutes that they can't sit because they've been doing it too much. They end up with a tight anal sphincter, and surprise, surprise, their continence is no better, and they're more frustrated. The main one I use is what's similar to Joe uses, is you're actually drawing the testes up inside the pelvis. If I can't get an appropriate contractional technique with that visual cue or that mental cue, I will talk to them about tightening up the muscles around the urethra, like you're stopping the flow of urine midstream. So I do sort of talk about all 3 of them, depending on the individual's level of I suppose, correctness in terms of what I'm wanting to achieve. And we do try to incorporate all at once. Okay. Now, a lot of the problems I see is tightening of the abdominal muscles initially. Quite often, if you activate your abdominal muscles prior to your pelvic floor muscles, you end up bearing down, and not only will you not help your continence, you'll actually probably make it worse and get yourself more frustrated. It's important, I always check for that, and I teach my patients how to check for that. Also, the overactivation of the buttock muscles and the inside thigh muscles as well. Now, in terms of correct prescription, with every exercise I prescribe, even if it's pelvic floor training or any other exercise prescription, you don't give this every person the same level of exercise because we're all different. I see a lot of patients, they come in and they go, oh, I can't really hold it for 8 seconds. They can't hold it for 1 second. So 8 seconds is just frustrating them, and they are getting into bad habits, and they are creating more problems, more harm than good, unfortunately. I do vary the position. Like Joe, I'm mainly prescribing standing, but if for some reason we cannot get a good contraction, I will position someone either lying on their back or side lying, or in sitting as well. I do encourage, though, training in all positions until they're dry at night, and then we just stop the lying down exercise and then continue with the sitting and the standing functional exercises. Now, we do talk about, like Joe spoke about earlier, the fast and the slow contractions to work on the fast twitch fibres and the slow twitch fibres. And I do prescribe various levels of effort. One of the other biggest mistakes I find is a man is very motivated to get this right with fear of leakage or fear of continuing leakage. So the level of effort is around 120%, if not more. So we do have to watch the level of effort because it usually is too high, and again, they will cause major problems. And I do incorporate incidental practice as well. And a lot of the exercises, particularly in the initial stages, is about 4 to 6 times per week. Now with the slow contractions, we tend to build up to 10 repetitions to be able to hold the contraction for 10 seconds with increasing various levels of effort. Now there is strong evidence to suggest that pelvic floor training preoperatively of at least 6 weeks with a minimum of 4 is essentially improving postoperative continence. What I've found in my clinical experience is even if those guys that initially have severe leakage, if they have worked hard building up to surgery for at least 6 to 12 weeks, their level of recovery and rate of recovery is much faster than what I've seen before, in terms of they may start initially leaking a lot, but because they're prepared and they've got that motor learning pattern happening, they will recover faster. I'll just skip ahead a little bit because we have talked about the slow twitch and the fast twitch fibres with Joe previously. My second pet hate is the breath holders. Okay, so it's important that you can contract your pelvic floor muscles without actually changing what's happening on your face. Okay, because if you're doing this, when you need to hold a mirror up, you're not doing it right. You're going to cause major problems. Okay, we also want to create new habits. Now, what I get my patients to do is every single time they stand up, they contract their pelvic floor muscles. If they forget, I get them to sit down and repeat it. And now I'm introducing not so much a punishment, but more of a reminder in terms of when you forget, sit down again and repeat it 5 times. You are going to get it sunk into your head eventually. Now, in terms of functional training, once you can actually elicit a contraction and you're improving, I make it harder for you by doing the same thing standing on one leg, floating up the opposite leg, forward stepping, backward stepping, introducing speed, and also preparing for return to the gym, running and golf, tennis and bowls, and also Pilates. Now, in terms of postural awareness, I'm going to just do one quick exercise. Now, our pelvic floor muscles work most effectively when you're sitting and standing in good posture. Okay, not slumping or slouching. Now, if everyone can stand up now. How much time have we got? Okay, 5 minutes. I'll skip the case study. He's doing well, so. Okay, if everyone has one hand on their lower abdominal area where their bladder is, and one hand on their lower part of their pelvis. Okay, imagine there's a bowl of water in your pelvis, okay, and it's floating. The bowl's there. We want to tip the bowl by tucking your tail underneath. Tip the bowl one way. Now tip it the other way. Okay, now I want you to find halfway between those 2 points. And that's where your neutral spine is. That's where you should be standing. That's where you should be sitting at all times. You can do this exercise in sitting as well. So make sure you tilt one way, then the other, and then find halfway. A lot of us tend to have it tilting backwards so the water comes out the front. Okay, we've got to tuck under a little bit to improve and activate your core muscles just by changing your posture. This is how you get abdominal toning, not through sit-ups. Okay. Does anyone have any questions before we have a quick look?
With incontinence, at no stage does age come into it, is that correct?
Look, not that it doesn't come into it. The question was, in terms of age, does that come into incontinence?
Repair time.
Repair time. Not necessarily. Look, I tend not to focus on age because it's so irrelevant and we can't change it. I see a lot of my patients vary from 34 to 78. My 78-year-olds are doing fantastically well. They're doing better than the 55-year-olds because they're very good 78-year-olds. So it comes into it a little bit, not just the number of birthdays you've had, but how well you've looked after yourself over those years. That's the most important thing.
Over the same 6 to 10 weeks, I'm nowhere near it, nor is a mate of mine. Is that the same sort of operation?
In terms of recovery?
Yeah.
There's so many variables in terms of why men leak and who leaks more. A lot of it comes down to preoperative education and training. A lot of it comes down to the surgeon, how many they've done, and their skill and technique. Sometimes I find with guys that have quite large prostates or aggressive cancers, like a Gleason 9, I would tell them to expect you might leak a little bit more because the surgery may have been more extensive. And again, if you're going to surgery with pelvic floor muscle weakness already, you're already a step behind.